Welcome to the We Talk Health Podcast, the official podcast for West Tennessee Healthcare. Please be advised that this podcast is not intended to replace any medical advice. Always follow your medical professional's advice and direction. Nothing said in this podcast is intended to supersede or supplement the direction of your medical caretakers. If you have any questions, please reach out to us at wetalkhealthpodcast@gmail.com, and we will do our best to answer any questions you may have.
Welcome to another episode of We Talk Health. My name is Kwasigroh, and today I am in Dyersburg, Tennessee, interviewing Dr. Ravinder Machra. She is a medical doctor at the West Tennessee Medical Group Internal Medicine Clinic here in Dyersburg. Dr. Machra, how are you?
Doing well, thanks.
Good. Thanks for coming on today.
Thanks for having me.
So, if you would, just tell me a little bit about yourself.
Sure. Like you said, my name is Ravinder Machra. I'm an internal medicine physician, board certified in internal medicine and obesity medicine. I have been practicing medicine in Dyersburg for the past 16 years, and obesity medicine has been added on for the past 5 years.
Today we're going to be talking about obesity and management. So, I guess we'll just start off by, can you give me a definition of obesity?
Sure, glad you asked. Because for the longest, the medical fraternity refused to believe it was a disease. We pretended it was not a disease, it was just something that happened to people who didn't care. We now know that it is a metabolic disorder, and it has to be treated as such. By definition, it is a chronic, progressive, relapsing, treatable, multifactorial neurobehavioral disease, wherein an increase in the fat, body fat, it promotes multiple adverse metabolic, biochemical, and psychosocial health consequences.
Okay.
In a nutshell, it's a multifaceted hormonal disorder which is actually reversible.
Gotcha. Well, that's good. It's good to hear that obesity is reversible, especially being in West Tennessee. There tends to be an abundance of that here.
Absolutely.
I am no exception.
Unfortunately, we are the red dot, as we would say,
Sure.
in the obesity. Yes, unfortunately, we have a high prevalence of obesity here in town and in the West Tennessee area. The national prevalence is about 42, and if I had to hazard a guess, I would probably say we are probably higher than that.
Oh, wow.
42% of people are obese.
Wow. I guess we'll just start off by asking, what does a typical visit with you look like? If people are dealing with obesity and they want to come to you to address it, what would a typical visit with you look like?
Sure. Usually, we usually do, when the patients come in for the first time, we of course take a thorough history. We try to find out or delve into what's going on, what's making them obese. And it's not, obese people are not lazy. Obese people are not gluttonous. Obese people are not obese because they want to be obese. Obese people are obese because there is a serious metabolic disorder going on and they are unable to control it. The way it is that eating is because you are overweight. You're overeating because you are overweight, not you are overweight because you're eating.
Oh, I see.
Most of the times, that's what I have to kind of needle out and talk about. And so we usually, what I do is we have a questionnaire that we let people fill out, and then we go through the questionnaire, and I try to kind of see if there's more psychosocial issues, or if there's more of control issues, or there is a major metabolic problem that is causing, like underlying thyroid disorder or insulin resistance is a big part of it, so we have to look at that also. So usually I do what we call a motivational interview. That kind of, I start off with asking permission from the patient. I explore whether they're ready. I mean, you might be overweight, but you might not be ready to do anything for it. We also kind of, from there, we assess what the patient's metabolic, BMI is, and how high the weight is, or where in the scales is he, and other drivers of weight, like I said, whether it is emotional, whether it is metabolic. And the next thing we do is we start off with discussing the risk of obesity. Of course, obesity comes with a huge load of problems, morbidities, and things that kind of push people towards a disease state. And then after that, usually once we are done, this usually takes a few visits, and we usually kind of develop a strategy based on what the patient wants and how I can guide them with my experience. And we agree upon a plan, and That's how we start off. Usually it is multiple things that go into it, since obesity is not just one single straight line.
Sure.
It's multifaceted.
Yeah.
So the plan, the treatment also has to be multifaceted. It cannot be just I'll give you medicine and you lose weight, or
Right.
I'll give you a meal plan and you lose weight. I'll give you exercise plan and you lose weight. It has to be everything done in conjunction.
Gotcha.
Yeah, losing weight is not really about just getting slim. It's not about aesthetics. It's about getting healthy, and it's about kind of strengthening your core, not necessarily just your outside look.
Gotcha.
So that's something that I kind of like to tell my patients that, hey, I'm not talking about your body. I'm talking about your health, your how we are going to progress and live on with this.
Sure. Well, I'm glad you brought that up. I was going to ask you, what are some good ways to be able to control those factors, like of losing weight, of sticking with a plan, like a diet plan, or using the exercise band?
Yes, sure. Again, based on what you are dealing with, based on the question answers that I get from my patients, the input that I get from my patients, we usually develop a plan, a strategy. Most of the times it involves, number one, trying to keep something that we call a food diary. I'll ask you, okay, what did you eat this week? And then that kind of gives me an insight into what the patient is looking into, and what the patient is eating and stuff like that. I do kind of write an exercise prescription usually for my patients. Usually exercise is not the first thing. Most of the times you have to understand that you cannot outrun a bad diet. So
Sure.
Diet actually is 70% of the weight loss journey.
Gotcha. Okay.
And most of the times it's not what you think. It's not like we are going to cut down the calories and we're going to lose weight. That's a myth. We cannot cut down fats and lose weight. We cannot cut down sugars and lose weight. And while all of these help, but it's not just about one thing. It's multiple things. And at the base of all of this, we have issues like insulin resistance that kind of come into play, and that kind of really and truly are at the top of everything, like the low carb diet, or cutting down the carbs, or the cutting down the fat, or cutting down the calories will come to a naught if the resistance of insulin is high, if the body has a high insulin resistance.
I see.
So those are the things that we usually do. So we have to strategize a plan for patients that kind of gives them multiple things. But I usually start with diet. There is, of course, I do cognitive therapy in the office, which means I counsel people about roadblocks. I counsel them about what to expect, and a little tricks to avoid overeating or giving into, hedonics of the food, as
Sure.
you would say, like greed of the food.
Right.
And that comes in the cognitive part of it. And then there comes exercise, of course. I said, although exercise is not the basis of it, exercise is essential for maintaining, but exercise is not the first thing that comes there. Like if you tell somebody who is 400 pounds to run or walk, you'll end up having osteoarthritis on your hands in addition to obesity. So you have to be very careful.
Yeah.
Pharmacotherapy is also a part of the therapy, which means we do use drugs, medications to help. We are using lots of medications that includes the traditional phentermine. Topamax has been shown in studies. Topiramate has been shown in studies to be very effective in losing weight. In fact, it has been the best so far that we have. We don't use it a whole lot, unfortunately, because of the side effect profile and long-term side effects, including dementia and memory losses and things like that. But those are some of the medications that we use. I also use some medications like like medicines that we would normally use for diabetes. Like GLP-2 agonists, and these medications are normally used for diabetes, but they do have a very nice effect on weight loss.
Oh.
And so I incorporate that in my patients. I usually say, okay, you're diabetic, perfect.
Right.
Now we can treat you. So that's part of it. So yes, it incorporates a lot of things. Exercise is one of them, and pharmacotherapy is part of it.
Gotcha.
But mostly it is diet.
Gotcha. So what is the prevalence of obesity?
In the country, in USA, when I took my ABOM boards, the prevalence of obesity was 34%. I just realized that it's in 2017, 2018, the numbers have gone up to 42%. And there's a projection that by 2030, we will be about 50% obese, which means 1 out of every 2 people will be obese. And when out of these numbers, 18% of youth between 2 and 19 are obese. And that's a sad statistics.
Oh, sure.
Because children who are obese will grow up to be adults who are obese. And it doesn't look like it's relenting anywhere. So that's going to be a problem. We also have some data from 2019 in Haynes study review that shows that only 20% of American adults have optimal metabolic metrics, which means that the circumference of the waist is less than 102 centimeters in men and 88 in women. It means fasting glucose less than 100. These are the metrics that we use for metabolic metrics that we use, and if they are high, we call it metabolic syndrome.
Oh, okay.
So only 20% don't have metabolic syndrome, which is terrible, and these people are like very high risk to develop complications from obesity.
You mentioned off mic clinical manifestations, or how is it present? So I guess my question is, how is obesity present in this area?
Yes. Let's start with what would you call obese? How would you say I'm obese? Well, we calculate the body mass index of a person. The body mass index, more than 25, between 20 to 25 is regular, average, normal. More than 25 is overweight. Between 30 to 34 is class 1 obesity.
Okay.
So 30 we classify as obese. 35 to 39 is class 2 obesity, and 40 is morbid obesity or class 3 obesity. So that's one way of saying somebody is obese. Your BMI is more than 30. There are other ways of calculating, like the body fat is also another way of calculating whether somebody is obese or not. Less than 15% is optimal in women, and less than 10% is optimal in men. So body fat. So we have a way of measuring body fat, and when it is more than 15% in women, we say, okay, you're obese. So that comes under the classification of obesity. So that's another way. And there are other ways, like waist, hip circumference. BMI does not really hold good for certain races, like Asian races and for our Hispanic population, the BMI really and truly does not give a very good picture of the obesity. Yes, they may have a higher BMI and not be obese, or they may not have a very high BMI and yet be obese. So in those populations, we try to use waist-hip ratios.
Gotcha. Okay.
So you were asking about clinical manifestations of obesity. We call it fat mass disease because basically it's the adipose tissue which is acting as an organ and causing all the disorders. So basically there is not a system in the body that is not affected by the fat mass disease. I mean, cardiovascular, we have congestive heart failure. It can cause, or it can be present with or without cor pulmonale.
Okay.
So we have varicose veins because we are overweight. The gravity takes over, and the varicose veins kind of cause problems, and they can have complications and things associated with varicose veins. Obesity per se also increases the inflammatory markers in the body. So there are different markers, cytokines and interleukins, that go up when somebody is obese. And those markers are secreted by the adipose tissue, or are released by the adipose tissue or the fat tissue of the body.
Gotcha.
And those markers not only cause joint pains and aches in obese people, but they also cause increased risk of thrombosis. So it's almost like obese people have thicker blood, not really thicker blood, but because they have inflammation markers in them.
I see.
So it can cause clotting, and they are more prone to have clots and strokes by that effect.
Gotcha.
Hypertension, of course, is self-explanatory. People who are overweight always most of the times have high blood pressure. The pulmonary side effects, the pulmonary system is involved with obesity too. It's difficult for people who have a higher BMI to walk without getting breathless. So dyspnea is there. There's something known as Pickwickian syndrome, which is certain because of the obesity. And also maybe they might have predisposing factors, other predisposing factors, but it leads to hypoventilation. They have short necks, they develop obstructive sleep apnea, and it causes hypoventilation syndrome. And that's also seen in fat mass disease. Asthma, of course, is seen more prevalent in obese people. The neurological system is also affected, and the neurological system is can be affected by way of stroke, as we mentioned, like thrombosis, increased thrombogenicity, and it can cause stroke. And then it can be nerve entrapments because of the physical fat mass. Also, there is some conditions called intracranial hypertension or pseudotumor cerebri. It usually is present in women, young females, but it is there is an association with obesity. Musculoskeletal side effects or effects of fat mass disease are osteoarthritis. I mean, you know that you have to carry so much weight on those two knees. Those two knees are going to give out, unfortunately. Immobility, myalgias, body aches, back pain, impaired balance, shifting of the center of gravity. Those things are the ones that cause a lot of pain and aches to people. I mean, you will see a lot of people who are overweight, unfortunately, will complain about all of this. The gastrointestinal side effects include hernias because there is only so much space in the abdominal area in the peritoneal cavity. And if the visceral fat takes over, then everything is pushed in that area. And it causes hernias, which means making the stomach go up or get pushed towards the diaphragm and can cause hernias or worsen hernias. Gastroesophageal reflux disorder, which is just pure reflux disorder because of pressure and also because of predisposing eating habits and things like that, can cause that too. Skin changes, like, of course, the varicose veins can progress to venous stasis. Lymphedema is a very typical problem of the fat mass disease, wherein there is subcutaneous fat deposits or subcutaneous fat tissue in the legs. And these people walk around with huge legs and they're painful and they develop ulcers and things like that. It's very difficult to treat it. That's one of the things that is very difficult to treat in obesity. So that is one more aspect. Of course, numerous cancers. There are multiple cancers that can be present or can be caused because of obesity. And there are lots of studies that are actually looking into the effect of obesity on cancers, but that's it. But if you actually treat obesity, or if you are able to lose weight, you will probably find that not only will you have better aesthetics, of course, that is there, but it also improves your lipid metabolism, reduces your blood pressure, it reduces your risk of thrombosis. Obstructive sleep apnea can be improved. People who lose weight who have obstructive sleep apnea and they lose weight, they actually see a good percent reduction in their symptoms.
Oh, wow.
Yeah. And of course, osteoarthritis, pain, it reduces onset of certain cancers and also improves the response to cancer treatment as well as reduces recurrences. In women, it improves the metabolism and also associated disorders like polycystic ovarian syndrome. Women who have it are usually overweight and are insulin resistant. So if you treat the underlying insulin resistance and obesity, which is kind of interconnected, you are very likely to help them. In men, it can help with hypogonadism, which can be either physical, just because of the habitus of the body, or it can be because of low testosterone levels. And if you lose weight, it can show significant improvements in that. One thing we need to understand is that obesity is very directly connected to insulin resistance. So people who are overweight, usually it has been shown in studies that usually they have high levels of insulin. Now, if they do have high levels of insulin, then why do so many people who are obese develop diabetes?
I was going to ask, those are my
Yes,
questions.
yes. So, well, it's very critical to understand that it's mostly metabolic. So once we understand that, we will not be judging. There's a lot of bias against people who are obese, because we look at them and we're like, oh, it probably doesn't work, probably doesn't eat in control, or probably doesn't have control of himself, or probably doesn't exercise. It's very easy to judge. But you have to understand that what happens is, anytime you eat food, we have three macronutrients: carbohydrates, the proteins, and the fats. These are the major macronutrients that we eat. So every time you eat carbohydrates, what is going to happen is the body is releasing insulin, and there's a cephalic part of it, and there's a gastrointestinal part of it. The cephalic part of it is where you are just thinking of eating a cake, and the body starts releasing the insulin.
Oh, wow. Okay.
And the gastrointestinal is when the food is actually in the stomach, and then the insulin is released to digest it, because insulin is needed to digest carbohydrates. So insulin normally, under normal circumstances, digests the carbohydrates into glucose, and glucose is our energy source. So what happens in people who have high levels of insulin, because of whatever reason, in those people, the insulin becomes defunct. It doesn't function as well.
Oh, okay.
So that's the biggest problem that we usually see in people. And studies have proven that people who are obese have high levels of insulin. So if you check the fasting levels of insulin in people who are obese, you'll see that they are high. Now, high insulin levels, even though they are high, you should not develop diabetes, but they do develop diabetes because this insulin is useless. It's not working as efficiently as it should. So that is the connection with diabetes. That is how it works with diabetes.
Gotcha.
The problem with insulin is that insulin is the factor or the hormone that sets the point for the body, or sets the point for the body with regards to its weight. So insulin tells the body how heavy you should be. So the higher the insulin levels are, the more obese you are, because it works on the brain and sets the body's weight at a certain point. The insulin resistance can be in multiple organs. It can be in liver, where it causes hepatic liver, steatosis or fatty liver that we call. It can be in muscles, and it can cause problems with sarcopenia, muscle loss, and things like that. The brain, even though the insulin works on the brain, but brain doesn't get resistant to insulin. So what that means is that even if the rest of your body has high levels of insulin that is not functioning right or is defunct, the brain gets the part of insulin and it responds to it. So while the rest of the body is struggling with insulin resistance, the brain is saying, oh, the insulin numbers are high, so we need to be obese. We need to set the fat point at a certain limit.
I got you.
And that is very critical to understand, that it's not what you eat that makes you obese. It's what your insulin numbers are that make you obese.
Gotcha.
And I've always been fascinated by it.
Sure.
And usually that's how I treat my diabetics.
Yeah. So what are some sugar substitutes that we could use?
So sugar, there are multiple sugar substitutes that are available: aspartame, sucrose, which is table sugar, fructose, which is the commonest sugar that has revolutionized the food industry. For the longest, the food industry has come up with the concept of high fructose sugar. The idea is the fructose is a fruit sugar, so it can't be bad.
Oh, I see.
Wrong. Fructose is a fruit sugar, but it's a highly concentrated form of fruit sugar. And when it gets into the body, the studies that have been done show that foods containing high fructose sugars can cause insulin resistance in as little as 7 days.
Oh, wow.
So you're better off eating regular sugar than eating high corn syrup or high fructose corn syrup and things like that. And that's what we are using because it's so cheap and so widely available. We are using it to sweeten most of our diets, most of our foods, most of our snacks. The problem is we see the high fructose. We see the fructose and we see that it's 50% glucose, 50% fructose, and it increases it has a low glycemic index, but it does increase your insulin resistance. So that's why it's bad in the long run.
Okay.
So that's one. The other thing that comes with sugar sweeteners and sugar substitutes is that the substitutes that are called zero calorie sweeteners or non-nutritive sweeteners, they don't increase your sugar in the short term. However, what happens is they do have an effect on the cephalic part of the insulin release. So the insulin that is released from the brain is released in response to diet-free diet also.
Okay.
So even though your sugar is not increased, but the insulin is increased. So the net effect on the insulin resistance is that it goes up.
I see.
So even though your blood sugar in the short term is perfect, so diabetics can take it in the short term, but remember that long-term problem will be you'll gain weight. So
Gotcha,
that is
okay.
that there have been multiple studies that have shown that Coke Zero, not Coke Zero per se, but diet sodas and diet drinks have been found to increase weight by virtue of insulin resistance in people over a period of time.
Wow.
So really and truly, while the short-term goal, which is wonderful if you're a diabetic and you know what you're eating, you can have a sugar substitute and keep your sugar down. But in the long term, you are going to gain weight because of the substitutes. And that's something very critical to...
Sure. Absolutely. So earlier we talked a little bit about exercises. So I know you mentioned you want to talk a little more about that. So what exactly did you want to say about it?
Well, quickly, exercise, like I always like to maintain that you cannot outrun a bad diet, which means if you are eating bad, there's no way you can lose weight by running.
Sure. That makes sense.
Yes, but all that's said and done in a well managed program where you are using exercise in conjunction with everything else, nutrition and behavior, lifestyle modifications, we can use exercise, and it can actually improve a lot of things. It can improve body composition. Like if you're doing exercise regularly, it can increase the adipose tissue in the body. That means reduce it. Dynamic training can cause weight loss, and resistant training can actually improve body composition, which means the fat can be replaced with the muscles.
Okay.
So that's amazing. That's wonderful. And usually, most of the times when we are prescribing exercise, I usually tell them how many times a week, what is the intensity you're going to use, how much time you're going to spend, what kind of exercise you're going to do, and what enjoyment do you drive out of it. That's critical.
Sure.
So, for most of us, you have to understand, most of us, less than 500 steps. Nowadays, we use a lot of pedometers, speedometers, and accelerometers. So less than 5,000 steps, if somebody is walking less than 5,000 steps, that's called sedentary.
Okay.
If you are walking more than 10,000 steps, that's active.
Okay.
This is normal. Like this is the basic that we recommend our patients. In addition, you could add 150 to 300 minutes of moderate intensity exercise, or 75 to 150 minutes of vigorous exercise. Now remember, any exercise that you do has to be done after you talk to your physician. So before embarking on an exercise program, you have to talk to your physician. But the basic thing that everybody can do is walking.
Okay.
So walking would not hurt. So if you walk for, say, 10,000 steps every day, you may not be able to start off at 10,000 steps.
Sure.
But that's the aim. That's the goal.
Okay.
10,000 steps every day for at least 3 to 5 days a week.
All right.
So that's it.
Gotcha. Well, Dr. Machra, this has been a great conversation. Listeners, if you are in the Dyersburg area and you maybe struggle with obesity and you want to talk to somebody about it, Dr. Machra is taking new patients right now. She is at the West Tennessee Medical Group Internal Medicine Clinic here in Dyersburg, and that's at 1718 Parr Avenue, Suite E. And their phone number is 731-285-9938. Dr. Machra, thanks so much for coming in today.
Well, it was a pleasure. Thank you so much, Will.
Absolutely. And this has been another episode of We Talk Health.